Welcome back to Tube Talk, everyone. I'm Brian Miller, your Associate Assistant Medical Director, here with episode number 4 now, and it's all about suction use. In our previous episodes, we primarily have focused on our blade work and obtaining our view that we need to be successful. However, that is all predicated on our ability to see our screen and keep it clean, and that is where suction comes in. That prevents us from contaminating our blade and ending our intubation attempt altogether. So we're going to talk about some tips and tricks on how to utilize suction to keep a clean view even under the most nasty of airway situations. I also want to touch a little bit on our system video reviews. We've seen a lot of really great technique out there over the last few weeks, and it's clear that our system is really adopting a lot of the Tube Talk principles that have been taught in these videos as well as in the cadaver lab. So a really great job, everyone. So let's build upon what we've already established and been successful with and continue that with episode number 4 now. As always though, let's start out with our 5 tips for intubation success. That's maintaining a 50-50 view every single time, deliberately curving our bougie, always staying midline from the tip of the tongue all the way down into the vallecula. We're going to talk about suction before and during in this episode, and then finally remember our rings right and inlet left maneuvers if we get bougie or tube hang up. This episode is going to be broken into 2 segments. The first part is going to focus on our suctioning prior to and during blade insertion, and then once we have built up those early suction skills, the latter half of this episode is going to focus on the full salad technique for those really contaminated airways. For those that haven't heard of salad before, don't worry, we will discuss it in a bit. I do want to take a quick second though to clear up a small misconception about the 5 tips for intubation success. Some people have thought that the salad part technique on the left side was required for every intubation. This move is actually optional, though it is a tool in your toolbox. This technique does add some complexity to our airway management, and so it doesn't always have to be utilized if we have a nice clean airway. Now that we have that cleared up and we have a plan for this episode, let's move right into our first topic now. Whenever we start out an airway, we have 2 suction approaches to consider. For a routine airway that's otherwise clean with minimal to no secretions, we can do our scissor blade suction technique. We're going to scissor the mouth open with our right hand, place our blade at the tip of the tongue, and then lead our blade with suction. However, for a grossly contaminated airway, we have no business placing our blade in without decontaminating that airway first. In this case, we're going to do our scissor suction blade technique. In this case, we're going to usually use our left hand to scissor the mouth open, and then add in suction with our right hand. By scissoring the mouth open, we're going to get a good mouth exposure so we can see what we're doing to decontaminate that airway with suction. Once we've sufficiently decontaminated that airway, then we place our blade at the tip of the tongue and start leading it with suction. This is how we're going to deal with a very contaminated airway and keep our blade clean. Whenever we're inserting suction into the mouth, we should be mindful of our hand hold and our suction positioning. On the left side, you see what we jokingly refer to as the dental hygienist hold. While this is great if we're at the dentist spitting out a little bit of saliva or some toothpaste, it's not so great for airway management. You see that suction is only superficially placed in the mouth there, and we also have an overhand grip, which requires us to twist or crane our wrist in an awkward fashion to get deeper. However, on the right side, you see what we call the dagger hold. It's exactly as you would be holding a dagger if you were going to stab someone. This allows us to use the suction device and follow with the contours of the airway all the way down to approximately around the glottis. This also allows us to trap the tongue just like a tongue blade and control that tongue as we're inserting the blade. So for those advantages, I would recommend you use the dagger hold for most cases. Another advantage of the dagger grip is that it allows us to multitask with the suction hand there. So in this case, you can see that we're scissoring the mouth open with suction already in hand. So we can scissor the mouth open, place the blade at the tip of the tongue, and then we're already bringing in suction right away. We're not having to search or find suction with that right hand. We're just ready to go. So this is a way that we can save a few seconds on our intubation. While verbally describing this all is great, let's go to a quick video on a mannequin to show how this all comes together. Alright, here we are with our suction already in hand in the dagger grip. We're scissoring the mouth open with our right hand, clear the back of the throat of all of those secretions, and then start working our way down the tongue with suction leading the blade until we obtain that 50-50 view and we're ready to go. In that last video, we saw a brief example of our suction leading the blade. Remember back to our very first Tube Talk episode and our analogy of a blind person and their white cane. The white cane leads the way ahead of the person, and clears the way, alerting them of any obstacles. This is the same thing for our suction in this case as well. We want to lead our blade well ahead with our suction to clear any secretions or obstacles out of its path. This is really critical for our trauma airways and most of our cardiac arrest airways, as these often have a lot more secretions than other airways. So let's take a look at a video of a really good example of progressive suctioning. This is a cardiac arrest intubation with lots of bloody and frothy secretions coating that airway. This is a high risk for contamination and overall a difficult airway that's made easy with good suction technique. We see the blade at the tip of the tongue now. We're going to see suction coming in and clearing this blade's path well ahead of the blade so it stays clean. You also see that suction is displacing the tongue out of the way so it doesn't get onto our blade. We adjust midline right here as we're going off to the left a little bit. And here the blade is placed into the vallecula now, and we have a generally 50-50 view right here. Airway's gotten much more clean after our suctioning. You see that the suction is placed in the salad park position at this point. And now we're just waiting for our bougie to come in right here. We did load the tongue off to the right side just a little bit, so that may be displacing our bougie just a little bit posteriorly, which is causing a little bit of difficulty here initially. It takes a few passes at the bougie now to actually get it in through the glottis here. But here we are, and we see we're at 10 centimeters now, 15, 20, and we're at 25, and this airway is on lock and is ultimately successful in about 65 seconds. In that last video, we saw good progressive suction use. However, even with the most meticulous of suctioning, there's often some fluid particles still in the back of the throat or some residual fluid pooling there. That's why it's important to keep your blade high and dry. What that means is that we need to continuously apply some upward pressure with our blade as we're walking down that tongue and getting into the vallecula there. If we release that pressure, oftentimes the airway will collapse and push our blade down into the floor of the posterior pharynx where all those secretions live. It's also important that we don't slide our blade directly along the floor of that posterior oropharynx, as both of these maneuvers can easily contaminate our blade. Let's take a look at a video now of what happens when we don't stay high and dry. This is a drug-assisted airway with ketamine, and the patient is continually breathing. There's a lot of lacy secretions that can easily contaminate our blade. So we place our blade at the tip of the tongue. We're starting to slowly advance. We see suction ahead leading the blade. However, we're not really staying high and dry here. We're actually dabbing the blade on the back of the airway right here. And we're going to continue advancing here and impact the blade directly with the uvula because we're still not staying high and dry. Now we're basically setting our blade on the back of the airway, which is a really high risk for contamination. And here we get splatted, and that's the end of that attempt. Now that we have the early components out of the way, I want to cover the entirety of the process for SALAD. As a reminder, SALAD stands for Suction-Assisted Laryngoscopy and Airway Decontamination. Many of us have a narrow view of SALAD being just the placement of the suction on the left side of the blade. However, it's actually this entire process on the right. We've already covered the first two steps though. We're going to suction at the start, and then we're going to do a slow, progressive visualization with the suction leading our blade tip ahead. And then there's this last step in the pink box. That's the salad part technique on the left side of the blade. We take our suction from the right, move it off to the left side, and then place it just above the esophagus to continuously suction. This is great for those cardiac arrest airways with a continuous buildup of secretions and fluid that we need to keep clear while we're trying to work on our right side with our bougie and our tube. I do want to focus briefly on the next slide though, on what hand is holding what and what side of the mouth each component of this process is at which time. On the left side of the screen, that represents the left side of the mouth. On the right side of the screen, that represents the right side of the mouth. We have a dashed line in the middle, dividing above it being while we're still obtaining our view, and below it being after we obtain our 50-50 view. We should always hold our laryngoscope in our left hand. We should never swap hands with our laryngoscope. On the right side, you see the hand in the dagger hold, and that is our right hand inserting the suction on the right side. While it may seem appealing for our partner to place suction on the left side already to suction for us, we need to be leading our blade with suction ahead of the blade, and so we need to have the suction in our right hand. Don't swap hands at this point, and don't have your partner do this for you. Now below the line, after we have obtained that 50-50 view. If we're done with suction and we don't need it anymore, we can drop suction and leave it out of the mouth. However, if we have continuous pooling of secretions, we're going to bring that suction from that right side over to the left side and park it on that left side. Now we have completely cleared the mouth to allow our bougie and then subsequently our tube to come into play. We should never maintain our suction on our right side while we're trying to manipulate the bougie. You either pull it out and leave it out, or you place it on the solid part position. This video highlights the issues of placing suction on the left side. So we see scissor blade suction, blade at the tip of the tongue starts walking down. However, suction is on the left side there in a very superficial position. We see torn secretions come right at the blade here, and we're not leading the blade well. It's actually very surprising that we don't contaminate our blade right there and end this intubation attempt. So we see the epiglottis just briefly up there through the secretions, but we're still not really suctioning anything out and having a lot of difficulty doing this from the left side. Had we entered from the right side with our suction, we could have easily suctioned all these secretions out and continued to work our way down. But now we're just kind of stagnant and sitting here just burning out time. Again, we get very close to contaminating our blade again as we're not really managing secretions very well. And then out of nowhere, somehow we find the epiglottis and place the blade into the vallecula right here. Actually, we're a little bit short. You can see this is a cardiac arrest and the epiglottis is bouncing up and down because we're not fully into the vallecula to manage that epiglottis. And now suction has actually been removed. You see the bougie come in right here. And I can't believe this, but this video is actually a successful intubation as the bougie passes right there. So lots of issues for placing the suction on the left side on this one. This video highlights the problems of maintaining suction on the right side when we should have pulled it out or transitioned it over to the left side in the salad part position. Here we go. We have scissor blade and then a little bit of delayed suction here. You're going to see it come in just a second, and there is suction now. This is a ketamine only drug assisted airway where we have the patient continuing to breathe and kind of kick back secretions. So suctioning is really critical. We see suction transition over to the left side briefly there. Looks like we're a little bit confused on when we should have placed our suction where. And now we have suction back on the right side, clearing a path, and it's overall a pretty clean airway at this point. However, then we maintain suction on that right side. Here's the bougie now, and it's kind of jockeying for position back and forth with the suction there, and we're really not able to get the bougie up and into that airway. So we see that we're kind of continuing to fight with this bougie and not really able to manipulate it as we should be because of that suction on the right side. We're continuing to have difficulty, and ultimately this is an unsuccessful airway at the end of this. This last video I wanted to utilize to highlight suction occlusion or obstruction by soft tissue in the back of the throat once it's placed into that salad part position. It's important to watch for this, and more importantly, listen to our suction for that occluded kind of grinding noise. Our partner can also listen to this, and they can start breaking that seal for us to make sure that we continuously suction in that salad part position. So here we are, scissor blade suction. We see this is likely a cardiac arrest airway with a ton of secretions present, and suction is leading our blade here, clearing its path. We see the tongue up in our face for a little bit there, but we make it around it, and we clear out this airway rather expeditiously, get our blade into the vallecula here, and generally get a 50-50 view. We actually back off a little bit to optimize that even more. Bougie comes in very nicely here. However, you can see right at the bottom there that suction is now stuck to the bottom of the glottis, and we're having a rising fluid level as it is no longer suctioning. We continue to see the fluid level rise, but luckily we get the tube into place just prior to kind of flooding out our view. So our suction could have been broken on that seal a little bit and have continued to suction. And that was kind of a lost opportunity on this airway. All right, that wraps up episode number 4 of Tube Talk, everyone. I hope you've taken away some new tips and tricks for suction use on your next intubation. And we're going to come back and close out our 5 tips for intubation success on episode number 5 and talk about bougies. I hope you continue to be successful on your airways out there. And until next time, take care and be safe, everyone.